Kind of a common case that a lot of us will see here, a newly diagnosed FLT3 ITD mutated acute myeloid leukemia, has some other mutations as well, TP53, SXL1, RUNX1, and then basically is coming to us here for evaluation. So Dr. Weinberg, I'm sure you receive a lot of cases of this nature. What would be the triage and workflow in the hematopathology and molecular lab?
So every bone marrow, especially for patients with acute myeloid leukemia, would get a morphological evaluation, the aspirate smear. We'll look at the appearance of the blasts, we'll look at the background cells, we'll look for dysplasia, we tabulate all those findings. And at the same time, we perform cytogenetic analysis, next generation sequencing analysis, sometimes AML FISH panel. And when all these tests come back, we can give a full WHO classification, which would take account presence of some of these cytogenetic abnormalities and mutations, and we issue a final diagnosis. But before those cytogenetics tests come back, we can say it's an acute myeloid leukemia, and of course, pending NPM1 mutation, we would say it's just AML. With NPM1, it becomes NPM1 mutated AML, and that's how we work up acute myeloid leukemia.
So what's the timeline from, let's say, you get the aspirate biopsy sample to issuing initial diagnosis, and then in your group in Brigham's, what are the main molecular that they're looking for, and how quickly are those becoming available, molecular and cytogenetics?
So we can look at an aspirate within a few hours of it's being done, and flow cytometry, of course, is being done at the same time. So within a few hours, we can issue a diagnosis of acute myeloid leukemia. The next generation sequencing, which at Brigham is called rapid heme panel, comes back within a week, sometimes about 4 to 5 days, because we have a few runs a week. And so we should have a full diagnosis within a week. Cytogenetic analysis, we can have a read within 24 to 48 hours.
Okay. And is it your practice that you're seeing that physicians are waiting for this information, or are they proceeding with treatment and then using the molecular as the treatment is going on?
Well, it depends. If it's an acute promyelocytic leukemia, some form of therapy will be started, but most of the time our clinicians will wait until next generation sequencing is back, because that will really determine which trials patients go on. So the results of that test is very crucial.
Yeah. Anything different we're seeing, Dr. Rizeri or Gergis, in your practice about molecular?
Yeah, I think you're in a very privileged site. For the turnaround you're providing to the clinicians is pretty good for NGS. In most of our sites, it takes a couple weeks, as you know, not to run the test, but because of all the data crunching that's required. And so while we run the NGS panels, we do a separate PCR for the targetable upfront lesions, which is, I think, probably what a number of the other clinical sites do. So we would search for IDH mutations as well as FLT3 with separate orderables for PCR to get that turnaround within the first couple days. Similar, as was mentioned, FLT3, obviously impacts our upfront therapy, and with recent approval, so with the IDH. At least on label. So we would look for the same things, but have to get to it a little bit differently to try to get the results in a rapid fashion.
So you would do, and I think we do something a little bit similar, where we do a 8-gene molecular panel, which is kind of a rapid panel that includes FLT3, IDH1, 2, NPM1, TP53, and then RUNX1. So the most important, and then you get the larger panel, we get it about 9-10 days, but that's usually not something we're waiting for in practice. But I think the point is very important, that I think today, at least for FLT3 for sure, as well as cytogenetics looking for secondary or MRC-associated features, is important, which we're going to talk about, and this actually impacts our standard of care. What about you, Dr. Gergis?
Similarly, we have our in-house panel that turns out FLT3 rather quickly, NPM, and then we wait for the rest, and it takes about 4 to 7 days.
Okay. What about IDH? Do you try to get the IDH before treatment, or are you really using it more for salvage decision?
We don't have, depending on the clinical trials that we have, so currently we do not have IDH up front, so we'll depend on it on the salvage setting.
For more for salvage, yeah.
Or whether clinical trial or standard of care.
Okay, okay. Yes, please.
I'm interested in your sense, maybe James and Olga's perception of the pathology here. This presentation with a high white count with the FLT3, and it's always unclear to me how I interpret the allelic burden and all of these other genetic changes. Do we think of that as the driving problem, particularly with this high white count? I I don't typically think of FLT3-driven leukemias as presenting with such a high white count necessarily. Maybe that's just my misperception, but
well, NPM1 mutated AML does tend to present with a very high white count, so in that sense it's pretty typical. FLT3, of course, by itself can present with also high white count, but so it's not necessarily unusual. Of course, it probably also depends on how long before the patient was seen.
Yeah. I mean, we commonly see the, FLT3 mutated patients presenting with high white count. I think your question is a very good one, is how does the allele burden relate to the white count? And I don't think that, we have not seen a clear correlation that those who are high allele burden will come with more leukocytosis or vice versa. And I think it's especially with the data that Dr. McCloskey is going to talk about, we don't even know therapeutically, if it has an impact. So we get the allele burden, but actually I think a lot of sites don't even get it. They just say positive, negative, but we don't really do much on it. What do you do, James?
Yeah, I think that's exactly true, and I think that where we find ourselves right now is in a position where we often have more information than we sometimes know what to do with, and I think we haven't yet standardized FLT3 testing well enough to kind of know where that allelic burden cutoff should be for high or low. And I think that, even if you look at the different guidelines, they often set that cutoff at different places. The different trials have used different cutoffs for allelic burden. And it certainly is one of the challenges I think we face, not only in this example in the upfront setting, but also later in the context of relapse. How do we determine which driver mutation is really the most important?
To target, yeah.
But I would also add that, variant allele frequency is very dependent on the kind of test that you use. And it may not even be reproducible from one NGS panel to another. We've recently reported on variant allele frequency in NPM1 mutation, which is generally a favorable mutation. Mm-hmm. But within those patients, it actually seems to subdivide into patients that don't do well, that have a high variant allele frequency. And in our study, it did correlate with blast count. So I think there's a lot that we're still
even between labs, you may actually not have the same variant allele, so that makes it even more complicated.
That makes it even more complicated, and so it's hard to draw that conclusion, but it does underline the biology and how much blasts.
Very interesting. Yeah, go ahead, James.
And I think one of the other things we're finding, especially as we have, fortunately, new therapeutic options that are available to patients, and some of these results become more valuable to us, is that sometimes even the quality of the aspirate itself is so variable. So as we start thinking about MRD and all the other molecular tests, if we have a sample that's drawn after 12 other milliliters have been removed, most of that's really peripheral blood, and how does that really translate, especially in this era where we really are making important treatment decisions? I think it's a real challenge for us.
Yeah, and that would influence the variant.
Go ahead.
So is it safe just to say that the allelic burden for FLT3 ITD has no bearing in treatment decisions today?
I would say, yeah. I think based on the treatment we're going to discuss, there was no difference, and I think if you're positive, and negative. Now, I think the one group maybe should you transplant people who are NPM1 mutated, low FLT3 allele, which is an emerging research topic, but today I think we would probably treat them, transplant them, give them midostaurin, and then move ahead.